Unshelling Medicine Podcast. Healthcare in the language we understand.
Hello, everybody. Welcome to another episode. Today, I have the pleasure of having with us Dr. Gosha. Dr. Gosha is an orthopedic surgeon and he has many years of experience, and we're here to learn a few things. So we're going to delve into serious conversations that are not only eye-opening, but also educational, because that is what we do. So, Dr. Gosha, welcome. How are you?
Thank you, Ms. Abe. I'm honored to be here and very happy to talk to you.
Thank you. Same here. So orthopedic surgery, that's heavy. So what interested you? I mean, there's so many specialties within the healthcare continuum. What interested you in being a spine surgeon, going into surgery? You could have done anything.
Yeah, it's always a matter of luck.
Yeah.
I joined this martial arts academy when I was 17. Within 2 weeks, the instructor, Pedro Valente, introduced me to Guy Scuderi, who is an excellent, well-known spine surgeon. And as a 17-year-old, I started doing some research with him. I knew I wanted to go to med school. I was really interested in his practice. We were doing chart analysis, so you could see the results. You could really, read through thousands and thousands of charts where you realize that this is amazing. If it's done correctly, if it's done ethically with proper indications, this practice can produce very rewarding results. And my personality, I know I'm very happy where I do something and I get immediate reward for it. So it was something very, very pleasant for me to learn. So Scuderi showed me what it's like to be a spine surgeon. And then he gave me some really important advice. He said, don't tell people that you want to be a spine surgeon. Maybe say you want to go into orthopedics, or say that you want to go into whatever field that you're learning about.
Yeah.
So that you learn more and they really take their time. So then I was lucky with some really great teachers along the way. So through my training in med school, I already tried and got good at delivering babies or straightening bones that are crooked after a fracture. Again, just luck of a draw, meeting the right people in the hospital, talking to them, learning from them. That's a lot of it was luck, really meeting the right people and showing interest.
Right. So basically showing that curiosity and the willingness to learn was really the key in having those people pull you in, because that's what it sounds like.
Yeah, it was like a humbling thing. You go and you stand there and you try to understand, and you appreciate that these people don't have to take any time out of their life to talk to you, but they're willing to train you and teach you, and they expect you to already have read about a topic before asking things.
Right.
They will expect for you to not do any worse if they allow you to participate in direct patient care than if they were the ones doing it. And we can discuss the issue about learning medicine on poor people at a different date, but that's in itself is a very important ethical subject to discuss.
Yeah, it is. So your training, was it here in the United States or was it in your country of origin? And the reason that I'm asking that question is that practices are kind of different sometimes, and we're talking about ethical concerns here. Sometimes you can find that ethical concerns are more pronounced depending on where you go. So did you find any similarities or any differences between your training and your practice?
You learn the model behavior in your training. And then in practice, you see various breaches of that, but you also see, in my field at least, really general adherence to the principles of surgery and the overreaching principles of do no harm. So look, it's exciting to talk about the bad apples, and it's important to talk about failures within the system. But that being said, this day and age, your expectations of 97, 99% good outcomes, theoretically, from a historic standpoint, 50 years of medicine, 50. And you're talking about a dramatic improvement in what we can do. A lot of scams, embarrassing scams, worldwide, world spread, stem cells, please. But the main direction of the medical community is to get better. There's no clandestine forces here. Yeah, the VC world is alive and well, and they are going to push in the VC direction. They are protected from really the feeling of sort of in the trenches, I got to get this grandma an MRI and No. What do you mean? No. What are you talking about? So the profit-driven sort of tangent is also alive and well.
It is. So you and I kind of like had just a small conversation before we jumped on. So in your practice, understanding that with VC level investment in healthcare and the focus being on profit margin, which we really suck at, we still suck at, even if that's kind of the focus. As a doctor, and I hear this quite often, and unless you're in a healthcare practice, you don't really understand the responsibility. And also sometimes I feel like the hand binding that doctors have to experience. You just mentioned grandma came in and there's something wrong. You want to order an MRI because skeletally you can see something is wrong and is like, no, it's not approved. So please, if you can speak on that a little bit, because it's easy to blame a doctor. The doctor is not doing enough to find out what is going on with me, or the doctor is not ordering enough diagnostic testing to get to the root of the problem and only focus on my symptoms. What has been your frustration with having to deal with all those red tapes and roadblock in a sense in prescribing care for your patients?
There's reasonably good evidence, I think a few studies, on the differences in healthcare delivery and utilization of resources, and most importantly, compliance. And the only variable that was associated with worse outcomes was communication issues and difficulty in asking questions.
Yeah.
So what you are doing with your podcast, You Don't Get Sick, is so important in that you are asking the questions that people should be asking. I'll give you a perfect example of an injustice that occurs all the time. You go to your doc with back pain, and the back pain continues despite all these attempts that may be futile in a lot of people. And then you continue with back pain, you have spine surgery, and it sounds like you've gone to the very end now. It doesn't get more serious than that. And then let's say that surgery takes 6 months to recover, because old classic spine surgery, it takes that long, 6 months. And then after 6 months, you don't get better. Now think about this. You don't get sick. You are out of work. You are taking narcotics. You can't sit. You can't stand. You are a burden on your family. You can't earn a living. You can't pick up your kids. Everything hurts. Everything every day hurts. These people exist in the millions. People who've had spine surgery over the past, let's say, 50 years. And with the classic methods, 36% have spine surgery and it fails. And they have to live like that now. There's been some very famous people recently who had spinal issues. And it's not that rare that you get a story about a doctor being murdered when there's some kind of an issue with a patient.
Yeah.
So there's an issue with these patients, and it stems from the fact that we didn't really used to understand where back pain comes from, but we do now. We definitely understand. And not only do we understand, we have a way to confirm where the pain is coming from. Because the one thing that patients need to get better is to pinpoint their pain. They need to know where it's coming from exactly. They need a diagnosis. If you have a diagnosis, you can provide a treatment that's indicated and you will get better. There is like a very high chance of that. That's how, going back to the original subject of why I went into spine surgery, because there was a way to verify. It was objective. Something so subjective as back pain or neck pain or mid-back pain, pain under the shoulder blade, or headaches, or pain going down the arm, or sciatica. There's a button. It's that simple. And there are minimally invasive ways to address it. For example, you don't have to have many times a fusion surgery where screws are placed to immobilize a painful segment. Now I replace those discs and they have normal motion. They go back to normal life. I had a 2-level disc replacement. It's been a game changer. Yeah, it's been really nice. Having no back pain, no sciatica, just being normal. It keeps you taller. That's the secret. We've figured out that back pain will be restored if you restore disc height. If you go from tight bone-on-bone arthritis, and then you give them some space, they do better. But if you immobilize, they do okay, and then other levels go bad. But if you give them back their height, but you replace it with a disc replacement, they move normal. Other levels move normal. It's a good time to be a spine surgeon because it really makes you better. I mean, it cures back pain, cures neck pain. You got to go through a rigorous process of figuring out where the pain is coming from. Trial injections in different spots, and you can go back to normal life. I did, for sure. And then imagine you have an operation.
Yeah.
You go through this long period, and you don't get better. And then you go to the doc, and they're like, I did a great job. No, I'm serious.
I'm laughing because it's true.
So 70 or 80% of what I do, 70 or 80%, that's a lot, are people who have already had spine surgery. Like that's sort of like my little tiny niche.
Right.
And I'll tell you, I hear the same stories.
Sadly, it is true, and it causes a lot of frustration. They talk about doctor-patient relationship. At that point where a patient is trying to communicate that a procedure, a surgery, however perfect you felt you did it, doc, it's not working for me. It's not helping me. And when that kind of communication is received, is dismissed, and it doesn't help that person have that trust that you can help them any further. Which brings me to my next question. Yes, we've now discovered this, and we're doing this game-changing procedure of replacing the disc. What happens to everybody with screws in their backs, with immobilized vertebrae, and with long-term pain? Because when we're talking about chronic pain or chronic disorders, that is one of the many chronic conditions. I don't want to use the word inflicted, but in a sense, it was inflicted through surgery. And unfortunately, we have opioid crisis and all those things. These kinds of things leave people on pain remedies long term. So what do we do for these patients now that we've discovered that, hey, immobilizing these, vertebrae is not the answer, is to give them that height and mobility. What are we doing for them?
All right. So the group that's suffering in back pain and is getting nowhere with injections, if they don't have deformity like scoliosis or from side view listhesis, they can get a disc replacement and you can cure their back pain. Same with the neck. For those people who have already had spine surgery, there are one of two issues most of the time. Either it's a problem above and below, that's called adjacent level disease. And for that, you can often sneak in with a disc replacement. If the level is deformed, obviously you just augment the fusion, but in a better position with additional height, as opposed to just the old school way of sort of leaving the spine, unfortunately, in the position where it was. So going back to the source of back pain, most of the time, is related in one way or another to loss of height. If you lose disc height, you lose space for nerves and pain going down our extremities. And then it moves your center of gravity forward. The more discs you lose, discs are in the front of your center of gravity. The more disc height you lose, the more you start to lean forwards. Hence, think about our grandparents. They're short and they're flexed forwards. So then you get other issues associated with it. If the issue is loss of height, then the solution, whether it's for adjacent level disease, that's a person who had a fusion already, or a person who's never had an operation, who is just done with their back pain, is to give them back their height. So going back to the people who have already had spine surgery, it's either above and below, or there's an actual problem with the operation. For example, sometimes well-meaning docs, in order to help patients with deformity, will put screws, and there is some chance that it's going to fail. Like I said, 36% with classic spine surgery. It's more like 3% with modern spine surgery. But still, there are some people who are going to have an operation, and it's not going to work, and you got to go back in. I have one message, so they're fixable. They're totally fixable. You just got to get a diagnosis. You got to figure out where is the problem. Now, look, not everything's fixable.
Yeah.
If the nerve got caught, you really can't reattach it. If the spinal cord is injured and someone's promising you stem cells, please don't do it. It's not going to help. But most of those poor folks who have a history of back surgery or neck surgery and they're still suffering, that's fixable.
Yeah. So let's talk about the risk, because I'm glad you brought in the nerve and also the spinal cord. There are some people that would rather suffer in silence or suffer through the pain of this degeneration rather than risk surgery because of the fear of paralysis or the fear of compromising a nerve that, again, may result in long-term pain. So what can you say to those group of people who may be listening to us right now have this conversation? Is it worth going through the process if with diagnostic testings we've pinpointed the source of the pain and they're a candidate for, disc replacement? What are the risk versus the benefit? Because in healthcare, the benefit has to outweigh the risk before we move forward with anything, right? Most procedure, I should say. So what would you like to say to those people who may be worried about the risk of this procedure?
I'm so happy that you asked that question, but it's a difficult question because it's a very personal question. When do the benefits of the operation outweigh the risks? it's a very personal question. I can tell you this, I can fix it tomorrow or 10 years from now with the same outcome. So from the point of view of like rushing because you don't want to have a permanent dysfunction, that only applies to people who have numbness or weakness. And even then, it really should not be an emergency. These things are fixed in a normal, calm way, in a very gentle, minimally invasive way if patients grow into sort of a younger generation of surgeons. Overall, the risks are somewhere in, let's say, 5% range for most spine surgeries. That means 5% of patients will have some kind of a complication. But that includes things like pneumonia after you have surgery, or a wound infection, or a heart attack. When the embolism, that's where a blood clot travels all the way to the lungs, and it can really hurt patients half the time. Almost half the patients die from that. Then you have risks inherent to that specific surgery. For example, when I go through the side, it's a very small incision, and the first thing I have to do is put a gentle feeler just to make sure I don't go through anything. Then, once I reach the right spot on the patient's side, specifically where we know there's no blood vessels and no nerves, you tap the pin into the disc, put a pencil, like a little tube on top of another tube, until you get to something like that big.
Right.
And then you operate through a tube that big, so you don't cut the muscles. It's really a nice way to fix most spine problems, except the very bottom disc. You can't get there. The pelvis is in the way if you go from the side. So for everything except for the bottom disc, the side axis is amazing. But what if the patient's blood vessels didn't read the textbooks? And what if where you put the pin actually is exactly where the blood vessel is for this particular patient? And we know there's quite a bit of variability in patients' anatomy.
Yeah.
So complications happen. You're going to battle. It's as serious as it gets. Complications happen, and you have to ask almost two questions. What's the total rate? And then what's the chances of having like a permanent problem? Because let's say you have a little more bleeding during surgery and it's a complication. You're going to be fine. Let's say it's a wound infection. Well, as long as the surgeon is right on top of it and immediately addresses it if he or she has it, it's done. What if there's a problem with the implant and back pain continues 6 months later, a year later? These people were doomed before. And now you can fix them. Sneak in, correct the problem, and sneak out. It's so rewarding. It's really it's amazing. So what are we going to do? We're going to help the patients that can be helped, and most patients can be helped.
Yeah. I think with a good outlook when it comes to the percentage being higher, I think people naturally feel an ease. And I absolutely, absolutely love how I'm somebody that I teach with jokes. And when you said that the patient's blood vessels didn't reach the textbook where they're supposed to be positioned, and that's what I tell my students, like, well, professor, why is this here? I'm like, the human body, it has a mind of its own. We're all structured very differently, and our bodies anatomically is very different. Just because you see an image in a textbook and they're telling you this is where this blood vessel is supposed to be located, doesn't mean it doesn't migrate in the formation of the human body. So in a situation like that where, unfortunately, if there's a major blood vessel that just gets in the way or runs through something and there's a case of hemorrhaging, and maybe this is something that was not anticipated. I know with every surgery, we anticipate some level of hemorrhaging and blood loss. And that's why we type and cross and make sure we have the right blood available for transfusion. So in a situation where we have to transfuse a patient maybe more than we originally anticipated, and people or a person maybe use that as an aversion to go into this procedure, what can you speak to that? Because it's very important for people to understand things that we anticipate to happen. And it's an emergency, but we don't completely panic over it because we kind of like, okay, so something like this may go awry. What can you say to that, to our listening audience?
Those are the rough times for these patients, and you got to make sure that before you go to battle, you have a doctor you trust isn't going to run away. I give my patients my cell phone number. I want them to feel comfortable calling me anytime. I think that's reasonable to expect, although that does go a little bit against the norm. You got to make sure that your doc is going to be there for you. And if there's a problem, you got to communicate with your doctor. Give him a chance. Get a hold of him, his nurse, and just address problems head on. There's continued pain. Why? What is the issue? Nothing wishy-washy. If you're not getting that from your surgeon, if you got caught with somebody who isn't that kind of person, but you didn't know it in advance, get a second opinion quickly. There's a problem, get a second opinion if your doc is not answering or addressing your needs.
Thank you. From a doctor, we've talked about it several times on this platform. Do not stick with one doctor. If you feel you're not comfortable or this doctor is elusive in the information being provided, please seek a second opinion. You have the right to do so. You're the driver's seat of your own health care. Please don't blindly trust a doctor if you feel within your spirit this is not the right person for you. This is a practicing physician, and you can hear it from a doctor. So it's very important. That synergy of trust is highly, highly important to your healing process. So, Dr. George, let's talk about relationship within interdisciplinary teams. When you go into an OR, you're not going into there yourself. You have your anesthesiologist, you have your techs, you have your OR nurses, and the list goes on and on. How important is it from an ethical standpoint and also from a practicing standpoint for everybody to be on the same page and for everybody to hold anybody in that room responsible to their ethical code of conduct? As you know, we don't want to talk about bad apples because we can talk all day and all year. How is that relationship and that interaction, how important is it that it needs to gel and everybody has to be in support of one another, especially when somebody's life is on the line?
That's communication between the team is crucial. There's really nothing unique about the medical team in surgery, probably than any other team of maybe 5 to 15 people. The titles mean nothing. Experience means everything. There is a hierarchy, but the reality is the hierarchy is just a distribution of jobs. It isn't necessarily a true hierarchy. These people aren't coming in to be over or under anyone, nor should they ever assume that. It just goes back to good old communication. I was rescued as a doctor by the nurses in the ICU in my residency. Rescued. I mean, in the beginning, the ICU is just the gates of hell.
Yeah, pretty much.
In the beginning, you really don't know what you're doing, and the nurses there, they run the whole show. As a medical student, I worked with attendings who allowed me to participate in certain activities in the OR, and I'm forever grateful about the leap of faith that they gave me there, and then being able to reproduce their hand positions and gentleness now in my practice. That's like 90% of surgical skill. You gotta be really gentle. So the team is essential. There's gonna be a leader. There has to be a strong leader. Everyone has to be on the same page. There's no space for anything other than good communication. The medical legal climate, it is already toxic enough as it is with all the forms and everything else. And some of those practices of repetition and checklists are excellent. But in the end, we're all just a bunch of animals, and we've got to communicate really well so we don't bite each other. So yeah, it's got to be friendly.
It's got to be friendly. What we know is not usually friendly. We have to do better. At the end of the day, we have to do better. I don't want to hop on the negative stuff because, again, this is not the platform for that. It's about finding solutions and talking about the things that we can change. So if I may ask you, is there any particular patient or scenario that sticks out to you where you made a difference? However, it was unconventional, because I think we all have that one patient or that one colleague who, you mentioned the ICU nurses coming to your rescue as a resident. Not for nothing. Let me climb on a soapbox here really quickly. Residents, most of them do understand the role the nurses play in their lives, but there are others that are a bit egotistical. Your success may just depend on a nurse coming to your rescue. I'm saying. So going back to my question, what is that one scenario that in your career has stood out and you'll continue to remember it, whether conventional or unconventional?
I did part of my training at Duke University in North Carolina. My old boss, Bill Richardson, used to have some very smart advice for patients. Can't say what the first one is, but the second one, let's just say it was all right. But the second one was to wrap the elbow with towels, big bath towels, a few layers, put tape over it so that you can go up to here, then towels bunch up and you can't hyperflex. He would tell patients to do this when they had elbow pain. And I remember so many patients would come back and say, all this tingling and numbness and elbow pain and arm pain got better, and it was not their neck after all. It was not their shoulder after all. It was specifically elbow and elbow problem. It's very common. Patients sometimes stay up all night with elbow pain. And I had a lot of back pain, and I remember those nights, and it's horrible. So imagine you just cannot go to sleep because your elbow is on fire, your fingers are tingling. You keep waking up with elbow pain. So I was thinking about it for a really long time, and I realized that you could just use a pillow. That was a breakthrough moment because I was like, well, just a regular pillow is going to be kind of silly, and I don't want tape. So yada, testing. I came up with this device that's like a pillow you wrap around your elbow. It's called Pillow for Pain. Pillow number 4 pain. It's got straps, and it's super comfy and cushy, like a nice pillow. And if you sleep with it, like if you put it on the first night, it stops elbow pain. And it felt so good because my little kids, my 7-year-old and my 12-year-old, 2 girls, very entrepreneurial. They saw the birth of this thing. They saw like me designing it. They saw me testing it. They saw me ordering supplies from Turkey and dealing with sanctions. And it was such an interesting pathway. My kids saw it, and now it's making people happy. We have professional athletes using it, and it's a game changer for drivers, for your airplane. It's like a beautiful, comfy, little luxurious pillow. It goes over your elbow. It's not very hot. You can sleep on it, but it will get you out of this hyperflex position. If you get out of that position, you won't get elbow pain. Your ulnar nerve will rest, the elbow will rest, the capsule will rest, and then you take it off, you're like, oh my God, my elbow is fine. The current devices, they're terrible. Either they keep your arm locked straight, you can't do it, you can't even get a drink, or it's just like a sleeve. A sleeve does nothing. You can still hyperflex. Pillow for pain. So I'm super, super proud of this.
Does he know you came up with this device and, it was from what you learned from it? Is he still alive?
You make a very good point. I need to tell him that he was the inspiration. I
Yes.
don't think I ever told him.
You should.
Well, I appreciate you saying this, Miss Obeah. You're right.
You
You inspired
should.
me.
Oh my goodness. Yay. I'm happy. I'm so happy for you. It sounds silly, but the simple things that actually fixes things. It's so important that we that out of the box thinking. This is innovation. Thinking the traditional way of doing things, or we've always done it that way. That's the big killer of anything innovative. And have you heard that a lot in your practice? This is the way we've always done it. Either when you have a new idea or of the way of doing things or treating people.
I have a story for you.
I love it.
There's this beautiful, beautiful man whose name is Professor Giles. He's the nicest guy in the world, and he's the head of OBGYN at Jackson. And Professor Giles, we're sitting once in a conference room all around a big long table. He's at the very head. I'm a student, so I don't know anything. I'm just taking notes on my phone. And there's like 10 residents all sitting around a table. But Professor Giles happens to he's a bit cross-eyed. One of his eyes is looking significantly like.
Okay.
And he asked a question, and I'm sitting on my phone taking notes on whatever he said before, not being rude or disrespectful. And the residents are like, come on, man. I'm like, what? I don't know what the question was. And then he says he's probably looking in the wrong eye.
Oh my goodness.
On a different note, Professor Giles is one of the smartest, most well-researched guys. And he said that 90% of what we do in obstetrics is based purely on tradition. There is no good evidence-based medicine related to the use of oxytocin. We do know it causes a lot of deaths. And I remember he said that it's the medicine that he thinks is the number one biggest killer in the world. I will never forget those words. In the end, my second baby was about to be born, and it was premature. But the doc was pushing it. And I was so dead set on my point of view of no C-section. And then they consulted a doctor to talk to me like a critical care kind of, obstetrician. And of all people on the planet that would have convinced me that it was the right time, it was him. So thanks to him, I was like, okay with my baby. Rio was born 2 months early, and she's perfect. Thank God. So she's perfect. And it was thanks to Dr. Giles. I gave him a big hug. I have a picture with him. It was like a moment.
So that teaches you don't look in the wrong eye. Okay.
How did you know which is the right eye?
Wow. Okay. So yeah, obstetrics. That's a different topic for a different day. We've got to innovation. That is one area of medicine. As a woman, that innovation is absolutely necessary. everything from the speculum to, delivery methods. We've got to come up with something, guys. We've got to. We women are going through it. We talked about quite a bit. Is there anything that you would like to change? Not necessarily change or have an impact on when it comes to your specialty. You've done this for years. You have the experience. You've been at the forefront of, treatment modalities that, improve patient lives. Is there anything right now in your practice or your specialty you would like to maybe see change or have a level of innovation, drive change, meaningful change that impacts lives in a possible?
Yeah, I want to remind you that we understand now back pain comes from discs. And we understand now that it's restoration of height that makes back pain goes away. So in order to achieve these goals, whether the classic way, mostly with fusions and loss of motion, or disc replacement, sort of the modern approach, you have to remove the remnant of the disc. One way or another, you have to scrape out the disc to get to the back where the spinal cord is and the nerves are. And that's the only way that you can take away the pain going down the legs, if you remove the stuff that's touching on those nerves. So you have to scrape out the disc. That's bottom line. We have scrapers, they're like little spoons, and then we have little circles that we use. And we have to be really careful not to ruin the bone.
Right.
Because if you fracture the bone, if you use too much force, and certain implants like replacements won't work. But I just want to remind you, we use little spoons and little circles. Come on. We're operating behind blood vessels or behind the spinal cord. That's crazy.
Yeah.
You have to use force in a very gentle way, right behind the spinal cord, while wearing a microscope on your face with a headlamp. You want to set yourself up for success. You want to have a patient where you have a good chance of not injuring the patient. So this is why spine surgery is so dangerous. But I was thinking, why don't we use a little electricity on the scrapers? Then you don't have to use any force. You could just paint. So in the OR, right at the base where the patient's feet are, there's usually a machine that generates electricity for our electric tools. One of those things we used to stop every little bleeder so that you can have a full operation losing almost no blood. Then that machine usually has 2 openings, but nobody has 2 of those tools ever in surgery, or at least not where I operate. So there's one that's open. So I said, well, why don't we wire the little scraper tool to electricity and connect it to a pedal? So this tool is the first since like 1970s that's an innovation in removing the disc. We're still using like Neanderthal tools, scrapers, and force.
Yeah.
And partly why some operations fail to work, the fusions, why they fail to knit together is if you leave too much of the disc. If you just take away 20% of the disc, I think 80% of it, the bone won't knit together.
Yeah.
So that's why so many fusions would fail. So the idea is then to connect it to AI and to navigation. So now, since you're operating behind the corner, you get to look on the screen and you can see exactly where you are. In fact, it can record your pathways. So like when you take a boat out in the bay, you can see your own pathways in the water from before.
Right.
Here, you could see where you've been. So this has been a big passion of mine. I'm excited to, I have a prototype, I've been using it, and it's amazing. It's just, as I said, you can use much less force in order to achieve a discectomy. So I'm excited to really have comparative data, and I'm excited to hear about the success of this tool and helping surgeons do a safer job.
That is so exciting. My goodness, yes. That is so exciting. I like that you are so innovative in your thinking, and it's very important that we as healthcare practitioners, we come up with the tools. I was at an AI innovation conference recently. I'm also in the health tech area. You talked about communication, the ability to be able to ask questions. I've seen that in my practice for 16 years. We're a country where people speak multiple languages, different languages. And, sometimes we have over reliance on ad hoc interpreters, which are humans. And there's a lot of errors that come from that. And we have all this legal settlements because of injury or mortality, right? Because somebody was not able to ask a question. So I did build a SaaS software that helps in real-time language translation in healthcare. So that is something that I've worked on, and it's ready, go-to-market ready, customer acquisition. That's where we are right now. So in talking about innovation, I want your take on this. I am of the mindset that it is important for us. If we're smart enough to do the procedures, if we're smart enough to plan patient care, if we're smart enough to be trusted to administer medication that could be life-altering? Why is it that we are still reliant on technicians or technical people to build a software for our practice or to build a tool for our practice while we trial and error? Oh, it doesn't quite work. Can we tweak it here? Can we tweak it there? And then we worry about policies and compliance and ethical issues. We're in the practice. We know the ethical barriers and ribbons, right? We understand how the tool should work. We understand how the system should work. Why is it that most of us are not being either encouraged or are not in that area of building something or coming up with something? I know we're busy. We're very busy. But I believe that more healthcare practitioners getting themselves into the innovation space will eliminate this trial and error mindset and practice. I don't know if you resonate with that or what your opinion is on that matter.
Yeah, absolutely. There are a lot of tangents here, a lot of vectors. As a father of two, I focus on my kids half the time, so it takes away from my time from innovating. But I really like this book by Atul Gawande called The Checklist Manifesto. And one of the last things he says in that book is that he would really encourage anyone involved in healthcare to continue to collect data, continue to learn, ask questions, and see if you can see answers through clean data. And that really goes back, Isobea, to our original point, my original belief in that, as data is so ample, the big winners are going to be those who can analyze the quality of that data.
And that's us. That's really us. We are in the practice and we understand. It's with the use of AI and, with certain platform, with the hallucination, we are on the precipice. We are the cusp of saying, okay, does this data work? Does it not work? Is this accurate? Is this not accurate? And I think with more of us involved in that process, there will be less likelihood of utilizing data that is inaccurate. And that is my belief. And
Absolutely.
maybe that's just my practice. I don't know.
Of course, I completely agree with you.
So as we wrap up this conversation, I am a sucker for knowledge and everything good. So I like to ask my guests to please leave us with a golden nugget or a few golden nuggets. What would you like our listeners to walk away from this conversation with?
This is very self-serving.
Okay, go ahead.
If you get a proper diagnosis, if you really are sure what problem you have a very good chance of fixing it. If you've had spine surgery before, you can fix the problem if it continues. If you have back pain and it's not amenable to anything, or neck pain and injections don't work, you can fix it. The risks are there, but you don't have to live in pain anymore. It's really nice to say that. At your service.
I love it. Thank you. So yes, if everything is fixable, it has to be with the right person. Please do not hesitate to get a second, third, or fourth opinion if you have to. Find a doctor that is right for you. Not every treatment is right for everybody. I know we alluded a little bit to stem cells. Look into it before you accept the treatment. And I hope somebody got something from this conversation. Please let us know if this was beneficial. You'd like to hear more from this. Even if you'd like to have a doctor back on, let us know. And we'll do in the show notes. I'm going to ask after this is a website for the pillow. So if you're having elbow pain of any kind and you want to try it out, you can go and purchase one and try it out yourself and see how it works out for you. But I thank you everybody for being here. And I thank you so much for being here with us.
Thank you. Thank you so much. I appreciate Miss Abea. You're so sweet. I love talking to you.
Thank you. Same here. Thank you. All right. Thank you, everybody. Bye-bye.
Thanks for tuning in to Unshelling Medicine Podcast. If you want to stay up to date with the latest episodes, make sure to hit that subscribe button on your favorite podcast platform. If you enjoyed today's episode, please take a moment to leave us a review. Follow us on social media at Altruistic Scribe on Instagram, TikTok, Facebook, YouTube, and LinkedIn. We share additional tips, updates, and health-related content that you won't want to miss. Have any questions or topics you'd like us to cover in future episodes? Reach out to us at altruisticscribeco.com. We're always eager to hear from our listeners and tackle the health topics that matter most to you. Until next time, stay healthy and take care.